عليكم ورحمة الله وبركاته. أنا اسمي هدى محمد الفاتح يوسف بدري. I'm a respiratory disease consultant based in Manchester, United Kingdom. This is a very short video, just giving a few pointers to clinicians looking after patients with chronic respiratory diseases who are at risk of COVID-19 or have contracted COVID-19, and to patients themselves who have these conditions. It's impossible to cover all of COVID-19 respiratory complications or indeed the management of chronic respiratory diseases in such a short space of time. So I'm just going to limit it to a few take-home messages. The first message I wanted to make, or the first point I wanted to make even, is that there is currently no specific treatment for COVID-19 infections. So all of the treatments that are available are supportive. So be it fluids, oxygenation or ventilation of any sort. And so it's absolutely vital that we prevent transmission and infection with COVID-19 in the first place. That's our best way of trying to control the disease, and it's certainly our best way of managing it in patients with severe or chronic diseases, because we know that they are going to do worse than somebody who is healthy. So just to give you an idea, COVID-19 infection in the general population has a mortality rate of between 3 to 4%, which is very high. I mean, annual influenza has a mortality rate of less than 0.1, so this is greater than tenfold that. But in patients who have uncontrolled respiratory diseases or who are immunocompromised in any way, or have chronic diseases, other chronic diseases such as diabetes or cardiovascular disease, their mortality is a staggering 15 to 20% if they have COVID infection. So really, prevention is the key to try and control this condition and reduce the mortality from it. Number two, we should all be adhering to social distancing now and should not be leaving the house for any reason whatsoever except for essential trips, so going to get shopping, medication or doctor's visits, or work if we have to, or if we have to look after vulnerable persons. People who have chronic conditions, who are elderly, so above the age of 65 or 70, or have uncontrolled respiratory diseases, should not be leaving the house at all now, and at least for the next 12 weeks, even for shopping for essential goods. That needs to be done by friends or family if that's possible in any way. And even at home, they need to be distancing themselves from others that are living with them, so not sharing the same spaces if they can, so staying in one area of the house as opposed to another, keeping apart from them if possible, no physical contact, not sharing washing facilities, and if they need to share them, if there is no other alternative, then they need to be thoroughly disinfected before use, and we should all be washing our hands at very regular intervals and avoiding touching our face or eyes, mouth with unwashed hands. The third point I wanted to make is that patients with chronic respiratory diseases such as asthma, COPD, bronchiectasis, cystic fibrosis, etc. Don't need to make any specific alterations to their treatments because of COVID-19. They don't need any extra antibiotics or to take as a preventer than what they would normally take for their condition. So if they're normally on maintenance antibiotics, they should continue taking those as prescribed. They should all have a backup course of steroids or antibiotics to use in the event of an exacerbation. That's just good practice. They don't need to take that to prevent themselves from getting COVID. That's not going to help the situation. What's more important is that those groups of patients strictly adhere to their treatment. So they're taking their treatments regularly. They're not missing out any doses. They're not they're not stopping inhalers for no reason. They're taking inhalers regularly and as prescribed, and that gives them the best chance at fighting off coronavirus if they did acquire, or if they develop exacerbation because of coronavirus, or if they develop coronavirus pneumonia. Because we know that people who have got uncontrolled or poorly controlled asthma or COPD are going to do worse. Now, there's going to be a group of patients who have severe disease despite taking all of their treatments regularly and despite being on the highest doses of all of those treatments. And some may be on biological therapy, so injectable therapies, to try and control their asthma. In those patients, it's crucial that they continue with all of those treatments. None of those treatments need to be stopped. They don't need to stop their steroids. Yes, steroids in general do cause immunocompromise, but if they've been prescribed by their doctor for their condition, they need to continue that, because the risk of stopping them outweighs the benefit, and certainly if they stop them abruptly, they can go into a crisis situation. The fourth point I wanted to make was with regards ventilation in the context of COVID-19 infections. So if somebody is unwell enough to be admitted to hospital with COVID-19, especially if they have signs of COVID-19 pneumonia, and certainly if they have signs of adult respiratory distress syndrome, then a discussion really should be had at that stage with them and their family, if they're available, or friends, with regards ceiling of care. Is this person going to be suitable for intubation or ventilation? We need to know that early on, because it's very possible that they're going to deteriorate further and they're going to need some form of ventilatory support. Now, the non-invasive ventilation can be used, so CPAP for hypoxemia, so type 1 respiratory failure, can be used as a bridge to ventilation, so that your plan would be that you're going to ventilate this person, or to help the other way if you're extubating them, or to try and prevent intubation. But again, a plan needs to be made before the person goes on to CPAP. Non-invasive ventilation in the form of bi-level ventilation or BiPAP is not recommended for COVID alone. If they've got an underlying respiratory condition such as COPD or a neuromuscular condition that can lead to that they've got type 2 respiratory failure because of, then yes, it can be used in that situation. But again, you need to make decisions about escalation of care. But if they don't have COPD, they don't have any other reason for type 2 respiratory failure other than their COVID, then really you should be invasively ventilating them or palliating them. I mean, that really should be where you're at. Now, it's possible that if things deteriorate and becomes a crisis situation, those choices may be more difficult to make if there isn't enough ventilators, and clinicians need to use their sort of clinical guidance in that situation. But if somebody's got type 2 respiratory failure because of COVID and no other underlying respiratory condition, then that is a bad place to be at. With regards to intubating patients with COVID infections, this really must be done by the most senior and experienced clinician because it's an aerosol producing procedure, and so we need to try and limit that to limit exposure of others to the infection, and if possible you need to be using video assistance. That's really all the points I wanted to make. All of this information is available on the British Thoracic Society website and Public Health England. I hope that this is beneficial to patients, to clinicians looking after these patients. Thank you.